frontline healthcare workers throughout this pandemic. Thank you. Next slide, please. And to begin, we would like to provide a brief background on our organization, the National Council of Urban Indian Health. NCUIH is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for AI and ANs living in urban areas. NCUIH is the only national representative of the 41 Title V UIOs under the IHS and the IHCIA. NCUIH strives to improve the health of over 70% of the AI and AN population that lives in urban areas, supported by quality, accessible healthcare centers. And next, we would like to acknowledge that this event is supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by CDC or HHS or the U.S. government. During this session, we'll introduce you to our project team, the overall initiative and its objectives, commentary from Evey Maho, a brief lecture, and then a commentary from our subject matter expert, Leila Ladnier, and we'll have a brief question and answer session on the lecture and then move into our overall discussion. And now I'd like to introduce to you our NCUIH project team. So we have Andrew Colwitt, Director of Research and Public Health Programs, Yvonne Ito, our Public Health Program Manager, Melissa Watson, Public Health Project Coordinator, and Lamar Weaver, Communications Associate. And next we have our presenter, Evelina Maho. Evey is from a small remote community of the People's Water, western portion of the Navajo Nation in northern Arizona. Evey has delivered Board of Director training for Southern California Consortium and Albuquerque Area Indian Health Service Board of Directors and other C-suite leadership trainings. Next slide, please. And next we have our subject matter expert, Leila Ladnier. Leila is a mother of 6 wonderful daughters of the Creek and Cherokee lineage and 6 perfect grandbabies, 2 of which are of Navajo descent. And Leila is also a nurse for 11 years. And now we would like to provide a wonderful video from our communications department on a brief history explaining how most American Indians and Alaskan Natives came to live in urban settings.
When you think of American Indians and Alaska Natives, do you picture this? Over 70% of American Indians and Alaska Natives live in cities or suburbs. Starting in the 19th century, federal Indian boarding schools governed by the doctrine, kill the Indian, save the man, took children away from their tribes and families, and the relocation era in the 1950s forced American Indians off reservations. Wait, so most American Indians and Alaska Natives live in cities? Do they all have the same culture and religion? Actually, there are 574 unique federally recognized tribal nations around the country, and many other organized groups, tribes, and bands centered in both rural and urban areas. And with more Native Americans living in cities than ever, urban Indians continue to celebrate their cultures and traditions. To learn more about how urban Indians are staying resilient and what you can do to get involved, follow the National Council of Urban Indian Health on social media.
Thank you, Lamar, for playing the video. With that, let's move into why we are all here. The Messengers in Health series focuses on vaccine equity for our UIOs. Today's session will be focusing more specifically on protecting our elders through vaccinations. So today we will accomplish the following. Identify ways to effectively communicate with urban Indian elders, share strategies to help improve trust between urban Indian elders and healthcare providers, learn about recommended vaccinations for elders this fall, and facilitate discussion between providers and frontline healthcare workers on elder care and vaccinations. And so now I'd like to pass the presentation over to Evey Maho to discuss the importance of our elders, especially during a pandemic such as this. Evey?
Thank you, Tiffany. Many of our urban Indian health organizations are founded by American Indian and Alaskan Natives who envisioned places where our people can feel welcome and a part of a community. Also to be healthy and well in body, mind, and spirit while away from our homelands. So our core traditional, the cultural, the spiritual values support, they support health and well-being for our Native communities through informed approaches of modern and traditional knowledge and beliefs held, taught and shared by our wisdom keepers, our elders. We can collectively move forward to ensure healthy people. We all know our elders have always known that cultural and spiritual protective factors are the essence of our tribal identity and our best medicine against many of the things that ail us today. Our elders have lived through so much and thus are resilient, and we believe that they help us to be resilient today, and are aware of what our people are facing today through their traditional stories. They have the wisdom of our ceremonies, customs, prayers, songs, the foods, the stories which will come with lessons. And they have ways of making sure that we're living in a good way. In many of our communities, tribes, in our dwellings, in our homes, it is this time of the year, the fall and the winter, that many of our stories are told. And through our efforts today, we truly want these types of important practices to continue. So it is in this spirit, this rationale, and for these reasons, NCUIH opens this virtual platform to talk about modern approaches to integrate into our traditional ways to keep our elders safe and with us. I will now give the floor to Leila. Or Tiffani.
Slide, please. No worries. Next slide, please.
I did.
Thank you, Evey. So now we're going to delve into some methods in improving communication. The COVID-19 pandemic has been so taxing in so many ways. So we just wanted to start discussing how we could talk with patients about COVID-19. So it's important to remember to be empathetic and collaborate with patients. Talk with, not at. It's also important to be mindful and respectful to ask permission to discuss vaccines. This shows that you're including and collaborating. Another method that can help improve communication is motivational interviewing. Motivational interviewing is helpful because it gets the interviewee to talk out loud, which ultimately helps in processing choices and decisions. And lastly, responding to questions about vaccines, health, or mental health is especially vital. It shows that you're actively listening and you care. Your response does depend on the competence, ethics, and scope of practice, but you can also refer the individual to the correct provider or expert for the support. Next slide, please. And so now we're going to take a look at the importance of tailoring information to your audience. So we're going to talk about how it's important to know your audience before just jumping into a discussion. You want to show that you have taken the time to get to understand your audience so your conversation is more personable and relatable. Once you have a good understanding of the audience, tailoring messages and resources to that audience is key. Getting the audience input and feedback is also important. You want to make sure that you continue to understand the needs of your audience, and that's an ongoing process. Next slide, please. And so next we have building trust. Trust is such a big piece of this. Improving communication leads to building trust. Being transparent about the process involving COVID-19 vaccines is key. We also want to empower our healthcare personnel, engage and partner with the national professional associations, healthcare systems, and healthcare personnel. Make sure that the healthcare systems have the resources that they need to support confidence in vaccinations, the importance of having empathetic vaccine conversations. We also want to make sure we're engaging our communities and individuals. So we want to empower our vaccine recipients, work with health departments and national partners to engage communities, collaborate with trusted messengers. Next slide, please. And so now we're going to take a look at the recommended vaccines for our elders this fall. So adults 65 years and older are at a higher risk for COVID-19, flu, and pneumonia. It is important to emphasize that and the importance not only to get the COVID-19 vaccine, but the flu and pneumonia as well. We have also included the link to the CDC's adult immunization schedule by vaccine and age here in the PowerPoint, which will also be sent following the webinar. And so now we're going to take a closer look at the COVID-19 vaccination. The risk of severe illness from COVID-19 increases with age, so protecting oneself and loved ones by getting vaccinated. And why the COVID-19 vaccine is important. COVID-19 vaccines are safe and effective in preventing illness. Dependent upon which COVID-19 vaccine the patient gets, discuss the need for the second shot 3 or 4 weeks after the first. It is important to increase immunity. For example, the Pfizer BioNTech vaccine COVID-19 booster shots have been authorized for specific populations, including the adults 65 years of age and older. The vaccines cannot make the patient sick with COVID-19, but experiencing side effects, which is normal as it's signs that the body is building protection against COVID-19. Next slide. And now we have the flu vaccination. So between 70 and 85% of flu-related deaths have occurred in adults 65 years and older. Between 50 and 70% of flu-related hospitalizations have occurred among adults 65 years and older. Adults 65 years and older are more likely to experience the flu more severely. This is due to the changes in the immune system that comes with increased age. So for this reason, it's especially important to get the flu vaccine annually. The best protection is by getting the flu vaccine. Ideally, the best time to get vaccinated is by the end of October. Vaccination should continue throughout the entire flu season, even into January or later. And now we have the pneumonia vaccination. Adults 65 and older should be up to date with the pneumococcal vaccination, better to protect against the pneumococcal disease such as pneumonia, meningitis, and bloodstream infections. Pneumococcal pneumonia is an example of a serious flu-related complication. So talking with the patient about this when they're getting their flu vaccine goes hand in hand. And next we have some other vaccine recommendations for our elders. So hepatitis B, important to discuss with the patient because of the liver and its functions as they change as age increases as well. So making hepatitis B more prevalent in older adults. Shingles, it's also important to discuss with the patient as age-related weakening of our immune systems can cause reawakening of the dormant chickenpox virus. 1 in 3 adults contract shingles and most are 60 years or older. And so now we'll take a look at some more vaccine strategies. So first we have ambassadors. So those would be trained community members who could provide important health information to their communities. Provider vaccination standardization, offering a vaccine as a default option during the patient's visit and integrating vaccination into the medical practice procedures. Medical reminders, messages that are sent to patients to remind them of recommended or upcoming appointments. These could be phone calls, text messages, mail. Motivational interviewing, patient-centered conversations designed to increase patient motivation and likelihood of health behavior uptake. Financial incentives. Financial incentives are to help motivate people to participate in a health behavior by providing a tangible reward for completion. Vaccination programs located at schools. Events that are held at schools to remove logistical barriers and increase vaccine uptake. Home-delivered vaccinations to meet people where they are, especially when there's transportation and access barriers. Workplace vaccination. So having an on-site workplace vaccination is another way that helps remove logistical barriers. Vaccine requirements. So having policies that require employees, students, or patrons to be vaccinated. Effective messages delivered by our trusted messengers. So messages that have been tested with the intent and produced desired outcomes. Trusted messengers are the people who have been seen as credible sources. Provider recommendation. Healthcare professionals recommending that a patient receives COVID-19 vaccination is important. And then combating misinformation. Misinformation is false information that's being shared by people who do not intend to mislead others. But disinformation is false information that is deliberately being created and disseminated to manipulate a narrative. So some techniques that help with false information: warning audience of misleading information, using fewer arguments to refute, and keep the factual statements simple. And this last strategy will also be part of our third community learning, which will be held on December 15th as well. And lastly, here are some evidence-based strategies that can also help with vaccine confidence. So we want to start tapping into what people think and feel. So if there's a low trust in vaccines, having educational campaigns that are more personalized, have employee health education and institutional recommendations which play into workplace. Then we have social norms. So if vaccination isn't emphasized, having an on-site vaccination helps with convenient access, and also incorporating institutional recommendations as well. And then we also have practical issues. So barriers in accessing the vaccine, which having on-site vaccinations is another big help. So offering it at the hospital or clinic entrances, work sites, just high traffic areas to increase access. And then also just reiterating that it's free and affordable vaccines. Next slide, please. And so now we would like to open the floor and the chat box to any questions that anyone has. So we could also like to invite Leila Ladnier to provide her commentary that brings all of this together. Leila?
Hey everybody, let me get my video going. Sorry, I had something in my eye, so I stopped the video. Like it wouldn't happen if I wasn't on video. So nice to be with everyone today. A little bit about my background, and this touches on so many aspects of my older nurses will say I'm still a baby nurse, 11 years, but I don't like to think of that because I've done so many things, and I'm so thankful and a little bit proud. But my work has been with elders of communities, but my whole focus was to work with Native cultures, and that's where I met Yvonne and got to live and work in Alaska, and now this amazing opportunity. And I cannot stress enough. I just did some new updates today on the flu vaccine because I spoke to a nurse practitioner the other day. He said he has not seen an actual flu case in a year and a half. And it's remarkable, and no one's really quite sure why that's happening, except for the fact that COVID is so dangerous. It is so susceptible. I mean, we are so susceptible to it. Our bodies have no immune system against it yet. So the flu, the regular common A and B flu, is not having an opportunity to really take hold yet, but that doesn't mean it won't. So it's important to keep up with our regular vaccines, our pneumonia that will help combat COVID pneumonia. The flu, certainly, you know, we don't want to have the flu and then our bodies be immunosuppressed and then COVID set in. So it's important to talk to our elders. If we can't get them to a clinic, can't get them into the hospital, are there traveling nurses? Is there a way to get a nurse to go to their home where they live? I know a lot of elders live in community homes where they have many people. They might have little great-grandchildren in the home as well as themselves and more people with comorbid issues. You know, everyone in the house is needing their vaccines. Let's get someone to their house if nothing else. I love all these strategies, the ambassadors giving good information. You know, you can't trust everybody for information. I wish we could, but that's not the way the world works. Let's make sure we're getting factual information. We're getting timely information. We now have boosters to our shots. Thank goodness. We don't know yet, because this is a new virus, we don't know yet the full length of our body's ability to hang on to the antibodies. So let's take advantage of the boosters and get those. We're not having too many shortages that I've heard of at all. I check the CDC regularly, and the shortages have pretty much been squashed. So there's no reason not to get them, except for access of getting to the facility. So, you know, if we band together, our elders are precious. They are you know, our mantles. They hold our stories, and we have so much left to learn. We want to protect them as long as possible, and when we're protecting them, we're protecting ourselves. I mean, it's you know, twofold. So I'm open to any questions. If anyone out there has any questions, please send them to any of us in the chat box. If you don't feel like piping up, but go ahead and pipe up. I'm happy to take any questions on vaccines or emergency plans, whatever questions you have. Suck it to me. Come on. Oh, there's something glitching there. I see some new names in the chat box, a few. Well, I know we had a few questions. Oh, let's see. Does NCUIH provide incentives to get the community getting the vaccines? Do you see that, Tiffany?
Oh, yep, I have it pulled up now. Sorry. Does
Okay.
NCUIH provide incentives to get the okay? I would have to defer that one to Evey. Evey or Yvonne?
Sorry, I didn't unmute myself. I just wanted to make a comment that we don't have incentives specifically from NCUIH that would go to community members for getting vaccines. However, we do have toolkits that our urban Indian health organizations, our UIOs, may take a look at to help build out some marketing, advertisement, and using language that would support and the work that you're all doing around vaccines in your respective communities. We also do have a shop. NCUIH does have a website. We can probably drop that in our link here. And UIOs are welcome to take a look at some of our products that really advocate for, you know, vaccines, and also just taking precautionary measures at the community level. Please, Cindy Fox Star, if you could just drop your email address, I definitely can help with some resources in that area and kind of point you into the right direction as well. But currently for this particular grant, we don't have incentives built in to provide to community members per se, but we can offer some recommendations on how to help support your UIO at that local level. Thank you. I see your email.
Thank you, Evey. I see we have something from Sarah. So often elders need coverage by more than one vaccine. How closely should they schedule different vaccines if a series of vaccinations is needed? Any tips on how to help elders decide on which vaccines are right for them? I think you're muted, Leila.
Yes, unmute, Leila. And usually you can't shut me up. And yes, that's so true. Many elders are behind on shots, many reasons, all across the board. Access, no one wants to really get another shot while they're not feeling well, and our elders are often, not always in the best of health when the shots come due around October and such in the winter months. So it's never a terrible thing to get several vaccines at once, especially if you're getting like a flu and a pneumonia. You can back those up. You could get 3 or 4 at once. But I personally don't like to, because some vaccines, some shots in general, do cause a little side effect, sometimes soreness where the injection is, oftentimes a low-grade fever. No big deal. Tylenol, ibuprofen usually takes care of that. But schedule them a week or 2 out. I would say if they're really, really behind, need like a flu, pneumonia, and say a shingles. I would do flu and pneumonia one day, and then maybe a week later, so come back and get the other one if that's an unavailable option. The way you know which ones they need that are right for them, I'm gonna say all of them, because as Tiffani pointed out earlier in the PowerPoint, our immune systems just kind of go out of whack when we get older. We get other issues, diabetes, we get high cholesterol. There's every kind of thing that we can get as we get older, or just lifestyle changes. We don't eat the same way. We don't consume as many vitamins and minerals. We don't drink enough water. Our liver starts to go kind of haywire, and our system just doesn't work as well. They need all of them. The shingles virus, for instance, chickenpox. If you've ever had it, you may not remember having it and actually did have it, because most of us, it is so infectious and it's innocuous. It's not as terrible as many other, like smallpox or something horrible and lethal, but it lives inside our body. And when we get older, our immune system gets weak and stops fighting off viruses that it recognizes that it just doesn't care about too much anymore. Shingles are terribly painful. They are awful. I have had patients with shingles across their eyes and in their retina, and it is a pain that my patients were just screaming. I mean, the highest painkiller I could give them wasn't helping, and it resolved in a week. You don't want shingles. Everybody needs their shingles virus. I think it's recommended at 45 or 50 and up. So every year, get your shingles. Every elder needs flu and their pneumonia shot. Pneumonia is coming hand in hand with COVID now, unfortunately, and COVID pneumonia is a killer. Of course, their COVID shot, but there are many other. There's hepatitis B, because our liver does start to kind of slow down as we age. It's worked a lot. It's doing a lot of work for the body. We want to make sure to keep up with those. So every one of those should be kept up yearly, unless contraindicated by your doctor. Their primary care physician would be able to look at their last known vaccines, and there's a website that's kept up with through across the board, so we all know what vaccines are, have been given or not. But definitely consult with a primary care physician, but don't be scared of them. They have very low side effects, and the benefits far outweigh the small side effects of soreness of injection or low-grade fever.
Thank you, Leila. It looks like we have another question. So are folks being recommended to take their flu and COVID-19 shots together, or is there a gap period with the COVID-19 schedule?
I have not seen anywhere where there was a gap period recommended, and it is not contraindicated because the shots are 2 very different shots. The COVID-19 is an mRNA. It goes inside. It kind of talks to the cell and says, hey, I need you to not respond to this virus that is, floating out there that you haven't seen before. That's just in a nutshell. That's how I told my daughters. I'm like, I know y'all are smart women, but I'm going to tell you like this because it's complicated and it doesn't just know it works, and it's been working, and it's been effective. And thank God, because we're losing way too many people to, this communicable disease. But I haven't seen anywhere where there's a gap period necessary. Your primary care provider may suggest something different, depending on comorbidities that you have. I went recently. I was sick, under the weather, was scared about COVID, lost my sense of taste, said I didn't have COVID, thank goodness. And I am up to date on my COVID shot. And I asked about the flu shot, and he said, yes, go ahead and get it. So I had just not, I guess my COVID shot's a couple months old now, but he did not recommend my booster shot because I'm not in that age population yet of where they're getting them, at least here in Alabama, very rural Alabama. But there's no need to wait. The flu shot works a little bit differently than the mRNA shot does of COVID. So they're not contraindicated. Get one in one arm, one in the other, roll on. The worst, I had the Pfizer, so I got the 2 shots. I had a sore area from my COVID shot. That was it. Both times, no other side effects whatsoever. The flu shot, the worst that I've ever had with the flu shot was I had a low-grade fever. And that is minimal in comparison.
Great, thank you, Leila. Are there any other questions? Give it a couple more seconds.
May I add that please feel free to message after. If you think of questions after this, we can drop all our emails in there. Just drop mine. I don't care. And if you have any questions, I'm happy to answer them or find the answers with you. I do not know it all. I don't even pretend to. But from those recovering from COVID-19, how soon should they be vaccinated? Immediately. Generally, I have seen that they are actually vaccinating people that have been hospitalized, who come in sick. They're vaccinating them there, in an effort to get a jump on whatever they already have, because this new variant, and there's going to be variants that come out until our body is able to recognize these and we get a great herd immunity. Unfortunately, it takes years, it takes deaths to get herd immunity, and we don't want to wait till then. So even if someone is recovering from COVID-19, they definitely should get vaccinated. Their doctor will have more information on that particular person, of course, because nothing is ever, like carte blanche. It's never for everybody. But it does not hurt to get the COVID vaccine while you're still recovering or while you're still ill from it, because it's doing the good thing of talking to the cells that are reproducing and saying, stop accepting this virus into your cell, basically. So get it as quick as possible. I hope they'll trust with our elders. Good question, Melissa.
So we do have something from Mark. He said he saw this regarding shingles. The effects of the Shingrix vaccine last year for at least 4 years in most people, and may last even longer in some. According to the Centers for Disease Control and Prevention, you do not need a booster dose after getting the 2 doses of Shingrix.
Yes, I've read that. I have a background in a nursing home population, and the particular type that our patients were given, it was a yearly for a little while until Shingrix came out, and then that was a much better one, and the second one. But a lot of people have the breakthrough, and I have seen where doctors have recommended that they actually get it multiple multiple years in a row, like 4 years in a row, because they were having such bad breakthroughs. And that's probably just their immune system, honestly. But if we have any kind of liver damage, our viral load is not as under control. Our immune system just doesn't always work with us when we're older and doesn't keep up as well. And the shingles I apologize, the shingles vaccine is an antiviral. And so what it's doing is it's suppressing the viral load. And when you have COVID is a virus as well, so that's the whole reason of getting the booster on top of this. But shingles is just a horrible, horrible, painful virus, and the Shingrix virus. It just depends. It could be works great in everybody, 90% of the people, and they never need another booster. But I have seen multiple where I worked for 4 years at a nursing home, and all 4 years, this one patient, she got shingles every year, and we gave her the injection every year because it would suppress it after she already had it, praying she didn't get it again this year after being vaccinated multiple times. But the injection itself would help suppress it, and it just wasn't quite as painful. So it's worth it if she had to get it again. A very minor thing.
Yeah, thank you, Mark, and thank you, Leila. And then next we have a question posed to the UIOs. So what would be some suggestions for organizations to implement to help build trust with our elders? Or for those on the line, suggestions of what you have done internally? Or Evey, if you would like to speak on that. Looks like we have Cindy. So calling on our seniors just to check in with them.
Yes,
Not sure.
Cindy, that's actually a really great recommendation. A lot of our elder and adult population, especially if they are really strongly rooted and connected to their tribal communities, their tribal practices, and things of that nature. We come from oral societies, right? Our people love to connect in different settings in different ways. And I think in today's time with COVID, we're restricted to do that. So calling upon our seniors and just checking in on them is a great way to do that. A lot of our elder population too, they connect to radio. If you're able to provide an opportunity where they can listen in on, radio waves, and you're able to communicate some of the language we're talking about today, that really is helpful. In your UIOs or your community partners, if you have community health representatives, public health nursing, or any public health, non-clinical staff that may be of assistance to you, or even like home food delivery programs, a diabetes prevention or diabetes management program staff. Those types of individuals are also, great support to the clinical team, to the nursing staff, and to the clinicians, to the providers, to be that extension to reach out and just follow up. The navigation, I think they're called the nurse navigators, or the navigation team members, or the clinical nurse case managers. They're also great extensions to just do a quick phone call. How are you doing? How are you feeling? I reviewed your records, and I see here, for example, you might be missing this particular vaccine, or Your immunizations need to be updated. So let's talk about how we can make this work for you. Do you have transportation? What kind of support do you have in your home setting? So those are some questions, some conversations to have at that level, and I think that would also be a good start. I think at an organizational level, it's really important to speak with your core team members and your ancillary support team members, your public health entity or community partners, and talk about what are we doing to make sure that the continuum of care for our senior population is there. So looking inside and asking ourselves as an organization, what does our current infrastructure look like, and what are some things we need to implement and or design or enhance to make sure that we are doing what we can to provide these services to our elders. Those are just some things I think I would recommend and encourage. And I think as I'm kind of going through some of these, I'm sure in the back of your mind, you might have your own ideas, because all of our settings are different and unique. So keep that in mind too. Everybody lives in different populations. Our settings are different. Our resources are different. And we connect differently too. And I think each of our UIOs will also have an understanding of how our population likes to receive information and to be reminded as well. And incorporating those things is really, really important. The other thing I would recommend, if you don't already have this, is that if you have a patient advisory committee or a group, make sure an elder citizen, a patient, is on that committee and they can speak to these kinds of questions and help to create and or enhance, programs and systems to be put in place as well. So those are just some comments I wanted to share just around that particular question.
Thank you, Evey. That was very helpful and very important. Do we have any other questions? Don't be shy.
I just wanted to add, on top of that, our collective bodies are just so drained and tired and exhausted and fearful this last year and a half. And, even though we're not on shutdown right now or lockdowns or any of that sort of thing, we fear that there's so much out there, but there's so much good, and there's so many people willing to help, reaching out to our community leaders and, hey, is there anyone available to go do house checks on our elders? There's a few we just haven't heard from in a while, and maybe they need things. I know a lot of the elders I've worked with, they didn't have transportation, or they lived alone, didn't have transportation, and were often without things, and we didn't know it until we came to visit, because I am too. I'm not going to say it's just for their for their status, but I'm prideful. I'm not going to always say when I'm in need of something. So possibly we could reach out to local organizations, and there doesn't have to be, close interaction. Show up on the porch. Here's a care package. Do you need anything? Especially if they're recovering, if they've been sick, or if there's family members that haven't been able to check on them in a long time due to work or, absence. So there's so many good people out there willing to help, needing to help, because what did Mr. Rogers say? His mom said, always look for the helpers. There's plenty of them. And it doesn't take a lot of money. If they're in the community already, they can stop by. Hey, if you schedule a doctor's appointment, I can help get you there. Or if you just need a case of water, we can get you that. Those are small things that we can do to help locally and get kind of an assessment, where our elders are. Anyway, my 2 cents there.
Oh, that was great. Thank you. If we don't have any other questions, we could move on. Okay, next slide, please.
Yeah, I'm tired of looking at me.
Looks like we're having some technical difficulties. Let me see if I can pull it up. My apologies. Oh, it's stuck. So we'll proceed. Sorry, Leila, looks like your picture is going to stay up for a little bit longer.
Oh my goodness.
But next, we would like to just provide a quick reminder about the survey. We thank everyone for their participation today. So if we could, we would appreciate your time and your comments and suggestions on how we could better serve you, as well as any additional questions you may like. So Melissa's dropping the link to the survey in the chat. Thank you, Melissa. And then next, just to touch on the next Community of Learning session dates, the next session will be on November 17th, and that will be talking about the flu, pneumonia, and COVID-19. And then we also have the third and final session on December 15th, which will be talking about vaccination myths versus facts. And then we also have NCUIH upcoming events. So charting your course, navigating funding streams to support your health programs, applying Indigenous data collection and evaluations to increase behavioral health grant funding. That will be on November 3rd. And then we also have Cedar Branch strategic planning for community advisory boards on November 16th. And then if we had the presentation moving forward, you'd be able to see the sources that were used for this presentation, excuse me. And then we also have a list of resources that can help in vaccine uptake and discussions with our elders, which we will also be sending in a follow-up email following this presentation. And then we just want to thank everyone again for taking the time to talk about this important topic regarding our elders and vaccinations. And if anyone needs anything, definitely feel free to reach out to myself, Leila, Evey, and we'll be happy to help. But thank you for your time and have a great day.